Hello friends, this is a incisional hernia which has developed after open cholecystectomy, and we will perform laparoscopic repair of this hernia.
Because Palmer's point is the most attractive site of the primary port position whenever you have any midline incision or previous laparotomy, or if the pathology is coming up to umbilicus. Like suppose you are doing myomectomy and fibroid is 20 centimeter, then you have to enter with the Palmer's point. Or the patient is pregnant and you have to do ovarian torsion, you have to enter with the Palmer's point. Or the patient has umbilicus hernia, umbilicus sinus, any infected umbilicus, then you have to enter Palmer's point. And Palmer's point is the most attractive site of the primary port position after umbilicus. Not only for surgeons, even for gynecologists, even for urologists. So this is important, and we should know how to enter with the Palmer's point. So this patient has open cholecystectomy performed before. We can see this is the scar due to the open cholecystectomy, and she has developed a big hernia. Right now you are not seeing hernia because she is supine position. So what is Palmer's point? This is the mid-clavicular line just below the costal margin, 2 centimeters below it. Okay. So this is the costal margin here.
राजा उसको भी रिकॉर्डिंग ऑन कर दो.
This is costal margin and this is mid-clavicular line. So this is Palmer's point. P for Palmer.
ये वाला ऑन है ऊपर.
This is Palmer's point. Here. This one. And this is below the costal margin. You can see it is fluctuating. There is no rib here. And what is the advantage? Just below is the stomach. And stomach is the only organ which you can easily aspirate by putting in nasogastric tube. And after that, it is very difficult to injure the stomach. But the problem of the Palmer point is that you have to repair, because 10 mm port again hernia can happen. So we have developed our own point. This is called Mishra's point here. This is M. So what is this point? This is over the rib. This is on the rib. This is on the rib. See, here I can move the patient here. Can you see that? This is rib. Now the question is how you will go with the rib. The rib is, what is that? That we will stretch it down. And see, this M came to P. And then we will go. What is the advantage? That anterior to the rib, it is impossible to have adhesion. And other advantage, after surgery, again it will go over the rib, so hernia will not happen. And here you will get 3 click. I will show you. First click is due to aponeurosis of external oblique. Second click of aponeurosis of internal oblique. And third click due to peritoneum. After that, here also similarly we will do irrigation test. This is irrigation, going freely, suction, nothing comes back, and then hanging drop, it is sucking in. After that we will attach the
प्रेस ऑन करो राजा. मैं टेस्ट कर दी स्टॉप.
towards the stomach. You should try to perforate the stomach, then you are safe. If you will try to save the stomach, you are in trouble. So toward perpendicular. Here also we go perpendicular. But because we lift the abdominal wall, so we are oblique to the body, but abdominal wall perpendicular. But here you have to just point towards the stomach. And nasogastric tube is must. And what you have, the one of the most important criteria, splenomegaly should not be there. And the good thing about
ठीक है.
हाँ ठीक कर सकते हो, हालांकि 1 के बाद करना है, लेकिन ठीक. So stomach, has the only part of the hollow viscous which can be aspirated by nasogastric tube. And once it is deflated, it is very difficult to puncture. Because deflated organ will be pushed down, because below the stomach there is a retrogastric cushion that is called omental bursa. Second advantage of a stomach, when it perforates, nothing happens because it doesn't contain bacteria, and stomach is muscular, it has one oblique layer of the muscle. So it will seal its own. Maximum if you will trocar, you will perforate, you only have to take one bite. Third advantage of a stomach is that stomach is a good organ to perforate. Why I am telling you that when notes is performed, natural orifices transluminal endoscopic surgery, then for the female they do transvaginal, and all the male the notes is performed transgastric. And in that they perforate the interior wall of the stomach and it remains perforated for a couple of hours while the surgery is going on. And then they take the organ like gallbladder to the mouth and they apply the clip. So the stomach, even if you perforate, it doesn't have bacteria to do bacterial peritonitis. So that's why Palmer point is very safe point. It is so attractive point that some surgeons they routinely use Palmer point for every case. You can see how now here the bulge of hernia is coming up. Can you see that? Bulge of hernia is coming up because gas will insufflate the area.
रिप के मार्जिन के पैरेलल नीचे की तरफ नहीं।
रिब के ऊपर के स्किन को ना वी पुल इट डाउन, रिट्रैक्ट करना। देखिए थोड़ा सा रिट्रैक्टेड, बट आफ्टर न्यूमोपेरिटोनियम इट विल रिमेन रिट्रैक्टेड, and once you will perform the surgery, once you will do it again, it will go over the rib, so you don't have to do port closure, and there is no chances of port site hernia, and there is no chances of any adhesion go anterior to the rib, तो वहां पर आपको adhesion भी नहीं मिलेगा. So we can see this is the bulge of the hernia which we have to repair. And you know hernia repair is of two types. One is called IPOM, another is called IPOM plus, another is called extended taper. So IPOM is done only if the hernia is smaller than 4 centimeter, like 2-3 centimeter. IPOM plus you will do if it is bigger. Here we will do IPOM plus. IPOM plus means first we have to repair it, and after that we have to put mesh. And extended tape is done if there is rectus divertication in that case. So this is done, and 15 is reached. So now we will remove it and then we will enter.
मैम गैस स्टॉप कर दो।
And this also should be pointed towards the stomach. So it has gone. Now we will clean and we put the telescope. थोड़ा सा और ऊपर, हल्का सा ऊपर कर टेप।
ठीक है सर।
हाँ थोड़ा, हाँ ठीक. So now we will clean the cannula and introduce the telescope.
मैम स्टार्ट कर दीजिए, 3 को 10 पर।
So here we are in and we can see the adhesion. So these adhesions are expected adhesion. So now the second port will be here, that will be 10 centimeter away from the first one. And then we will do the adhesiolysis.
So now adhesiolysis is started, and we are using harmonic scalpel to do the adhesiolysis. We can see these all are omentum which is adhered with the anterior abdominal wall, and this was due to the previous open cholecystectomy. So you have to be careful that in these jungles of the omentum there may be hidden a small bowel loop also. So slowly adhesion should be removed bit by bit. Left hand you should support the anterior abdominal wall to give little pressure, so that when you do adhesiolysis you can have some advantage of the left hand and you can have some tactile feedback. So we can see here the hernia is visible. We can see a black hole over the anterior abdominal wall, and it has a lot of fatty content, and this is the falciform ligament. So basically it has developed over the epigastric area. So we will separate some of the part of the falciform ligament, so that once we will suture this hernia, and after that appropriate size of the mesh we can put it, and we can repair the hernia. So this is the membranous part of the falciform ligament, and this is the fatty part. The reason being why it is necessary to remove at least 6 centimeter all around the defect, you should have healthy domain so that you can put the mesh, you can fire the tacker, and you can do the intraperitoneal onlay mesh application. In this area we can see the small bowel is there. This is the small bowel, so care should be taken that by mistake the tip of the harmonic should not touch the small bowel. And you should be as nearer as possible to the anterior abdominal wall. So this small bowel is carefully removed from the adhesion part. Here we can see this is the liver, right lobe of the liver, and these all adhesion has been developed due to the open cholecystectomy. Patient is around 65-year-old and long back, maybe 20 years before she has gone through the open cholecystectomy. Here we can see this is the defect, and a lot of fatty content is inside the defect. So first thing that we will remove all the content of the fatty content of this epigastric type of hernia, because otherwise it will be painful. As we know that most of the epigastric hernia has a preperitoneal fat, but in this particular case it is not a pure epigastric, this is a incisional hernia, but all these fat has to be removed. This is the surrounding, and with the defect also we will remove all the fat. With the left hand you can press the finger over the defect. For the time being we are keeping it over the liver, later we will remove it out. And this is the with the left hand pressing the defect, and all these fatty content of the defect we will remove out. So with the left hand we are pressing the skin over the defect, so that any of the fatty content should not be remain inside the sac. And now almost all the content is taken out. So we can see there that this defect is easily visible, and it is just the bare skin which is visible. Now little more part of the membranous part of the falciform ligament we will separate, so that we have a safer margin all around the defect to put the mesh and fire the tacker. So now it is almost enough. Now we are using here the barb proline. This is the barb proline suture to suture the defect, and then we will use mesh. So this is IPOM plus, that is intraperitoneal only mesh repair after repairing the defect. And this barb proline has an advantage that it approximates the tissue under tension also, and it has a loop in the beginning of the suture, so that you do not have to tie the starter knot, and just you can pass the needle through the loop, and then automatically it get locked, and then you can suture the defect. And another advantage of this barb is that it does not return back. However, little suturing on the ceiling is little challenging. Robotic is much easy for suturing on the ceiling, but it is also not very difficult. You can do it. And now we will pass the suture through the loop, so that it will automatically lock. And this is quite a strong suture, non-absorbable of course, and it does not return back. It is unidirectional, so it only goes ahead and it does not come back. So you do not have to lock it also, and you can continue the suturing. So this is a starter. So this is a completely unedited video. Almost we have not cut this video. Only we have cut at couple of places where the cleaning of the telescope was required. So you have to hold the needle upside down, because we have to take a bite on the anterior abdominal wall. So tip of the needle should be down, and then you have to rotate it, and then we should go out to in and in to out. So this is out to in. Skin should not be pricked, and however skin will not be pricked also, because the gas will keep the anterior abdominal wall skin over the defect lifted up. So easily you can take a bite over the rectus and you can close the defect. So we can see this suture is going only in front. When you are progressing and tying the knot, it does not reverse back. So after tying the knot, once the gap is approximated, this gap is not again opening. So, it is approximated, but we will further continue and we will reverse it, we will take 2 layer, so that it will be much a strong closure. However, even if you have closed it by proline, better to use mesh, because not using mesh has a high chances of recurrence. So, in spite of nice closure, we will use the mesh, and here we will use the tie mesh, that is the titanized mesh. Titanized mesh look like proline mesh, but it is reinforced by the titanium, it is a composite mesh. So, this is what we are going to use today. So, now the first layer, first row, not layer, first row is complete, and now we will reverse back, so that it will go further a strong closure. So, this is the final bite which we are taking on the healthy area, so that we can terminate the suture, and there is no need of, in the barb suture there is no need of doing the Aberdeen termination or the surgeon's knot. So, now we will cut the suture and then take the suture out. We are cutting little bigger the suture, because ultimately it will be covered by the mesh, so it will not expose to the bowel. So, this is the mesh which we are going to use in this surgery. This is the tie mesh, and after removal of this proline barb suture, with this port we will introduce the mesh and fire the tacker. We have already marked it outside, however, in this case we are not going to do the transfacial fixation, because this is a small hernia. So, directly we will fire the tacker, the transfacial fixation will not be performed. Care should be taken that center of the mesh should be in the center of the defect, and it should project all around the margin of the defect, bilateral symmetrical, it should not be one side more, another side less. So, this is a titanium tacker which we are fixing, and outer as well as inner crowning will be performed. So this is just a simple case of incisional hernia. These type of cases are very easy to perform, and if you will do primary closure as well as good mesh placement, and here you don't need to do extended tape or any pre-peritoneal surgery, that is unnecessarily increasing the risk of seroma and you are making the simple surgery difficult. So this is the inner crowning and it's almost over. After that we will take a grasper and this fatty content which we have cut it out from the sac, we will remove it slowly and then we will do the port closure also. This port is better to close because there should not be again hernia. So these are all the content of the sac. Slowly you can take a uh, means artery forceps and then slowly you should pull it out because this is fat, so it can easily break. Care should be taken in the wound also, you should not have any content left behind, and with the betadine you should we should clean the port nicely, and then with the same barb suture which is left a little bit, we will do the port closure. Port closure should be taken with all the layers including the aponeurosis and the peritoneum all. Here we are using the suture passer. With the suture passer, barb suture is introduced from one side of the wound and it is taken on the another side, and we will tie the knot all the layers except skin. So thank you very much for watching this video. This was just a simple case of incisional hernia. Have a nice day.